Hello, welcome to another episode of Surgery Talks podcast. My name is Afshin Alijani. I'm a consultant surgeon based in Dundee, Scotland. For this episode, I'll be talking to Mr Stuart Suttie, a consultant vascular surgeon at Nineworth Hospital, Dundee. I'll be asking him about the management of patients with acute limb ischemia. Stuart, today we were going to talk about acute limb ischemia. I would like to ask, firstly, how often do you see this problem in your clinical practice?
I think we're seeing it less frequently now. Hard to give a true instance, but maybe once or twice a month.
Okay.
We might see a true acute limb ischemia.
Okay.
I think we're seeing less because we're getting much better medical management of the processes that might actually cause acute limb ischemia.
Okay. So if you encounter an acute limb ischemia, what would be your kind of initial thoughts and how would you approach that?
Initial thoughts, I have to think, overall you've got to look globally at the patient. You've got to think, what is ultimately, what has caused it? And what other things may mimic it? I mean, acute limb ischemia is a sudden loss of blood or blood supply to limb. And that can either be through occlusion of your native artery or a block bypass graft. So we've got to, take all that into consideration. I think at this point, I'd just like to emphasise that it is a true acute limb ischemia is different from acute on chronic limb ischemia, which is what we're seeing more of in comparison to acute limb ischemia. And the reason to make that distinction is it's a different urgency and different management to that disease process. And
so there's acute limb ischemia versus acute on chronic limb ischemia. So by that you mean, for example, a patient who acute on chronic is a patient who has a past history of, say, intermittent claudication and presents acutely with an exacerbation of symptoms.
Yeah, exactly.
As opposed to a patient who's never been complaining of any disease symptoms.
Who's got no history of atherosclerotic disease, no prior claudication.
And acutely presents with signs and symptoms suggestive.
And hopefully, that's we'll broach that later, I hope, but that's where the history and examination can be crucial because it can really help you make the distinction between the two.
So what would be the causes for an acute presentation?
So I think the main causes we see are mainly cardiac. We're seeing they've got this elderly population. The main thing we see is atrial fibrillation, post-myocardial infarction, valvular pathology, and really, like all the textbooks say, is an atrial myxoma, but I think I've seen one in my whole life.
So as a source of emboli?
Source of an emboli.
Yeah.
So the embolus is the main thing we do see. Ones from the heart, they're usually large emboli, and they'll lodge in distinct places in the arterial tree. And these places are inherent areas of narrowing, and that is where the arteries divide, such as the common femoral, where it divides into superficial profunda, or the popliteal, where it divides into anteroarterial. Just inherent areas of narrowing, big clots lodge, get stuck, and they can propagate.
Okay. All right.
So you've got to remember, emboli could just be as blood, but it could also be air, or another sort of fatty deposit. But the things we also see are the atheroemboli. These are cholesterol-rich plaques that have, they've embolized from an atherosclerotic plaque. They're very small emboli. It's not so common. We tend to see that after we've been performing interventions with wires, and we might knock off a bit of plaque. We also get thromboemboli, something similar, where you get a ruptured atherosclerotic plaque and you get a thrombus adherent to it, and that thrombus propagates, almost like a big tongue can develop, and at some point that tongue will break off and move distally. And we do see that, from big plaques up in the aorta, present with an embolus. You can't find an obvious course or cause, and you do the imaging, there's an atherosclerotic plaque that's probably been the primary source. Ones we see rarer are the arterial dissections. So you've got to keep that in the back of the mind. Trauma, we're seeing more of that, especially the iatrogenic. And you can also get external compression.
What, give us an example of one.
The last one I've seen recently was a upper limb, and he had acute limb ischemia. It was very small emboli, but the actual primary cause turns out to be on pathology, a big lymphoma compressing the subclavian artery, and it caused thrombus to develop, and it just embolized distally.
You also mentioned iatrogenic trauma. What would be an example of that?
So iatrogenic, it can be ourselves in theatre, especially when we're doing the percutaneous over-the-wire interventions. We can cause sudden occlusion of an artery. We also see it following, trauma. Trauma procedures such as orthopedics, manipulating the bones, drilling things in, plates going wrong, it can damage the vessels. So we do see that.
Okay, so if you say, imagine you're receiving a phone call about a patient and the query is acute limb ischemia, what are the kind of things that you would like to hear regarding the history and also examination?
Things we want to do are certain. You're right. There's certain things you want to pay particular attention to. You're going to ask about the pain. Classically, it's a sudden onset, comes on with a bang, and it's excruciating. It happens in the peripheries, and it may then progress more centrally. It's extremely rare for it to be an isolated segment, such as just occurring in the thigh and ignoring the peripheries. It can happen, I suppose, if you get an isolated embolus going down a specific artery, but usually it blocks off the larger arteries, and it's the distal part of the limb you feel. So it's a sudden onset, excruciating pain. The pain itself is constant, and it's worse on moving the muscles, whether that's active or passive movement. We also look for other things as well. We look for the duration of symptoms. This is really important. It can actually help you guide management. You've also got to look for, the history might give it away as the cause of the acute limb. You may want to ask the patient about palpitations, any recent chest pain, sudden onset shortness of breath or cough, any known dysrhythmias. If they're known to have a dysrhythmia, are they on an anticoagulant? What is their recent INR, for instance? It's not uncommon to see someone with known AF coming in with a subtherapeutic INR with a cardiac embolus. And then, as you mentioned before, you broached on the acute and chronic being a sort of a function of native arterial disease. And I think this is where the history and examination can really come in, because they are two different distinct pathologies, but we'll pay particular attention in history of things like intermittent claudication, because that is a giveaway. That is a different pathology. That might be what we call a thrombosis in situ, or acute and chronic ischemia, where there's an underlying native arterial narrowing. It becomes so critical, it thromboses off. That's the history. Examination, we have classically from all the textbooks are the 6 Ps. Pain, pallor, the limb's perishingly cold, it's pulseless, develop paresthesia, and that can progress to limb paralysis. And I think it tends to occur along that pathway.
So that's the kind of a order.
That'd be the order. Yeah. Mm-hmm. The pain is intense. It affects the muscle compartments as well. When you're looking at the muscle compartments, you might get asked, if you're the examining surgeon, what do the muscles feel like? Do they feel soft and fleshy? Compare it with the other leg or the other arm. Or do they have a woody, a woody, tense feel? And that's a sign that there's going to be underlying muscle damage in that compartment. And that could be a sign of irreversible damage to that muscle compartment. It doesn't mean the leg's irreversibly damaged, it could just be that muscle is irreversibly damaged. The limb goes pale. Why? Well, there's no blood getting into the limb. So the limb is initially white, but also what you can see, if the leg's on the flat or slightly elevated, you can see where the veins have been, because they're empty of blood. There's no blood getting in, so we call that venous guttering. You get a little guttering effect in the foot and the distal calf. As it progresses, some of the questions again we're going to ask to the referring individual would be, what is the colour of the leg now? And what we're paying particular attention, is it white, or is it developing something that we call mottling? So mottling is it's a blue purplish discoloration. Again, happens in the peripheries, working its way centrally. And we're paying particular attention to, we call it blanching or non-blanching mottling. And how do we assess for that? Gentle thumb pressure over the area of the purple discoloration. Take the thumb away. If the tissues underneath are white, and then gradually refill with that purple colour, it's blanching. That usually means it's quite severe ischemia, but the limb's probably still salvageable. And then we compare that to non-blanching. So the same test, gentle thumb pressure to the area, but the tissues underneath don't turn white. That is a sign of irreversible ischemia. And we call that non-blanching. And then further down the pathway we have the paresthesia, which can progress to paralysis. Again, sensory motory defects, they're indicative of muscle and nerve damage. The nerves really do not like a lack of blood, hence the sudden onset of pain. And if there's paresthesia, the leg is probably still salvageable. When it progresses to paralysis, it depends on the extent of the paralysis, whether or not the leg's salvageable. And I suppose this is where experience of, your breadth of experience over your training comes in. So those would be the key things we might interrogate a trainee on over the phone at 2 a.m, and that can help us decide what we need to do.
Do diabetics still get acute pain in their leg?
Good question. This can be quite difficult because there's diabetic epidemic, and one of the problems is they can actually have paresthesia as well. So some of them they'll have a good neuropathic problem, and they might not get the pain. However, that tends to affect mainly the toes and the forefoot. And we're talking about if there's a good going embolic source here, high up in the arterial duplex, the muscles
that will still be sore.
But it can be hard to ascertain the degree of paresthesia.
Yes.
Because it might have long-standing paresthesia.
And presumably you also always be comparing all your findings with the contralateral limb.
I think that's important. Why? I think a true acute limb ischemia in a young individual, what I'd be looking for is, one, a known cause for an embolism. I'd like to see a full complement of contralateral limb pulses. And with this, no history of something like intermittent claudication. Part of the problem we're now facing is we're getting an ever-increasing elderly population that might actually have asymptomatic arterial disease underlying all this. So we might not always get that now. And that can be tricky, because there might still be a true acute limb ischemia with an embolus on a background of stenosed arteries, or is it a thrombosed stenosis in chronically diseased arteries? And they're a different ballgame.
And this is where the imaging might come into that we will come back to. The use of handheld Doppler, would that be something useful in your practice?
I think one of the problems with Doppler is it's how you actually interpret it. It's not uncommon to say, I've picked up a Doppler signal, there's not a problem with the leg. If you look at somebody, they might have a chronically occluded leg artery, yet the foot's still pink. There's going to be a signal due to collateralizations. What we might do, if we're using a handheld Doppler, is listen to the waveforms that are generated in the pedal vessels. And these range from monophasic to biphasic to triphasic. Triphasic and biphasic are essentially normal. Monophasic implies a very damped flow to that periphery. And by definition is obviously an obstruction, whether it's acute or chronic. So I think handheld Dopplers can be helpful, but they can also be unhelpful, the way they're interpreted.
Sure. So so now we've established that the patient has acute limb ischemia. What is the next kind of thought process? You mentioned something about whether the limb is salvageable. Is that?
I think true. It's
and how would you kind of distinguish salvageable with? So if you want
very good. So I think it comes on the history and examination. Is it irreversible? Is it non-blanche mottling?
Yeah.
So I think the first thing I would look at, are we dealing with something that's salvageable, or is it non-salvageable? And thereafter, you're going to decide what imaging, what treatment modalities we are. So if it's looking at the limbs salvageable, it's a function of the history and the examination, the duration of the ischemia, and the extent of the thrombus. The reason why I'd want to know, I think it's salvageable, I think attempting to salvage an irreversibly damaged limb from ischemia, it will lead to death. You're essentially reperfusing a badly damaged limb. There's a lot of dead tissue there. The dead tissue, you've got muscle degradation products, they're essentially toxins. And you get cardiovascular collapse, you get multi-organ failure.
Renal
failure goes off, clotting goes off, heart-lung problems. Generally, the whole body hemostasis rapidly deteriorates. So it's crucial to make that, and it can be very hard to make that judgment call.
So the timing is critical. What are your kind of time scale in the process of management?
I think time is of the essence.
Mm-hmm.
I think, if we're going to salvage something, the quicker we do it, the better the functional outcome of the limb. It's not unknown for us to salvage a limb to find out they've got really badly damaged nerves, ischemic neuritis, they've got a nice pink foot, but it's non-functioning. We can break it down into time. The books classically will break it down 0 to 6 hours and greater than 6. I think it's a very grey area and every patient's different. And this is where, again, the experience comes into it. I tend to break it down into up to 4 hours, 0 to 4 hours. And that's 0 as in that's the onset of the symptoms. Not the timing of remission, but the onset of symptoms.
So that's often, by the time the patient has arrived in the hospital, that's your 4 hours is pretty much over, isn't it?
It is. And we see it a lot more now where patients are sitting at home for a good 6 to 12 hours before calling somebody.
Yeah.
So the clock's already ticking.
Yes.
The first few hours you're going to have a white, painful foot, sensorimotor defect. The limb's usually clearly salvageable. When I say salvageable, it depends on what's needing done, but it should still be salvageable.
Sure.
I then say maybe 4 to 12 hours. It sort of straddles that 6 hour period. The limb may become mottled, but it might still blanch on pressure with minimal paralysis. The ischemia may be partly reversible, but it should still be salvageable. It's when you have the long delays, the greater than 12 hours, unfortunately we do see it when the patient presents with fixed mottling, it's non-blanching, the distal compartments in the leg, they're tender, they're red, the limb's paralysed. I think that's a fairly clear-cut, non-salvageable limb that we wouldn't attempt to reperfuse. But it can be very hard at 2, 3 in the morning. You don't have a good light in the ward. Some of the curtains are blue. It makes anything look mottled. So it's going to have experience comes into it.
So if a limb is clearly non-salvageable, what would you do for that?
So there's 2 things we can do. We could consider amputation. Now, an amputation can be a good operation. We've got to consider the level of the amputation and the function the patient will get afterwards, but it can be a life-saving procedure. Or we've got to consider palliation. What might drive you either way is the symptoms, the signs, clinical examination, and ultimately you've got to look at the patient. You'll see it in general surgery, the patient's becoming increasingly frail, multiple comorbidities. An amputation might not be in their best interests.
So if it is salvageable and time is now of the essence, would you image these patients?
I would.
And how would you image them?
So I think that's a good question. It's something we commonly get asked. So why would I image? I think when I first started out, I think if we had a good cause for an embolus, no signs of claudication or full complement of pulses elsewhere, you might think, okay, we can maybe crack on, do an embolectomy at 2 in the morning, not always needing imaging, or during the day we might get an arterial duplex. I think now we're seeing a lot more asymptomatic arterial disease in the background here. And I think our unit's practice now is we would image them all, irrespective of what time of day they come in. Our preferred choice is based on our local expertise, and what we have available would be a CT angiogram. I think it doesn't really add in much delay as long as you get the nature of the pathology and the time, the essence of time across the radiology staff. They do it very quick. It gives you all the information you need. I would image from the diaphragm down to the toes, but it does require access, a lot of radiation and contrast, but it's a necessary evil if you want to save a leg. So CT. We can also use arterial duplex. That's very operator dependent, quick, but there's a lot of what's what I'm looking for, interpretation by the operator. Other units may use an MR angiogram. We don't really have the facility to do that out of hours on a rapid sequence, so we don't do that. We can also use the old-fashioned, which is catheter angiogram or digital subtraction, but it is invasive. And again, it needs a bit more setup. So our method of choice is a CT angiogram for all patients if we're going to think about limb salvage.
So for CT angio, what are the kind of things you'll be looking for?
So the CT angiogram, We're looking from the aorta down to the feet. I'm looking at, is the aorta nice and clean? Is there any signs of atherosclerosis? Because that will help distinguish the acute and chronics. We're looking to see where the site of the occlusion is, looking to see the extent of the thrombus, and that allows us to plan intervention, where we want to extract the thrombus from. But I think you mentioned it before, I think it is crucial with the imaging. It will help you ascertain if there's underlying atherosclerotic disease. You have to be suspicious there's an underlying stenosis there, and that is a different management.
So once you've done your imaging and urgently, and it appears that this limb is salvageable, so what is the surgical management of that limb?
Okay, I think, yeah. So again, it depends on the degree of ischemia. Do we need to retrieve the clot? And we don't always have to retrieve the clot to obtain limb salvage. An operation is high risk, it's high tire of surgery, and the big differentiation we see is between the lower limb and an upper limb ischemia. The upper limb has a lot more collaterals. It may present profoundly ischemic, but after a few hours the collaterals will kick in.
Upper limb.
The upper limb, and you see the arm begin to reperfuse.
Yeah.
And you've got to remember, a lot of these patients are elderly and frail. We're not aiming for perfection. They might be better off having a limb that claudicates than having a big complication. So that depends on the symptoms and the site of the embolus. You've got to see, can the thrombus or the clot actually be retrieved? If it's so distal and it's plugging off, let's say, all the crural vessels all the way down into the feet with no normal vessel beyond, you've got to be suspicious that we might not be able to actually salvage that. And then it's how you're going to do it. How do we do it? I think the standard method, the one that we're all familiar with, is an open embolectomy using a Fogarty embolectomy catheter. That's just a little catheter with an inflatable balloon at the end. You pass the catheter beyond where you think the clot is, gently inflate it and pull it back. We've got other tricks up our sleeves now. We've got catheter-directed lysis, so we can place a catheter down into the clot and instill a thrombolytic agent. That takes time, not always successful. It can cause distal embolization, but we use that for acute and chronics. We can do catheter aspiration, sometimes use that for the SMA, embolectomies. Instead of a big operation, sometimes we can direct the catheter in and try and aspirate the clot out. And it's certainly one of the methods we use if we've done an angioplasty on somebody and created acute limb ischemia. We'll try and do a catheter aspiration. And we can also use mechanical thrombolysis. We get some nice devices now that will instill thrombolysis and mechanically disrupt the clot and aspirate it out. But we tend to keep that for things like a prosthetic graft occlusion, where you know you're not going to damage an arterial wall.
So let's just say the patient, you've decided on a surgical approach through an arteriotomy. Could you just go through the technique of a transverse arteriotomy and how you do it?
Of course. I think you've got to make sure you pick the appropriate site, and then it comes back, a clot's going to lodge when artery narrows. That's where the artery divides. So let's say you get clot in the common femoral, and it's extending down the superficial and the profunda. So you expose the common femoral any way you wish. There's longitudinal, there's obliques. Everyone's got their own way of doing it. And it's all about following basic arterial surgical principles, which is control the inflow. That's the blood coming down from the heart to where you want to make the cut, and controlling the runoff. Because blood will come around another way and come back out the hole you made from distally. So for the common femoral, we would expose the common femoral, the origin of the profunda, and the origin of the superficial femoral artery. We tend to use slings for these. We would then site our arteriotomy just proximal to that bifurcation. Why? Well, it's much easier then to actually direct the Fogarty catheter down the branches, so you can be a bit more selective in your clot retrieval. You said we do a transverse arteriotomy. That is a standard teaching. Why a transverse arteriotomy? Well, if the artery's healthy, you've got to think about how you're going to close the artery. And when we're closing an artery, we need to evert the edges so you have intima to intima. And if you're using transverse, it will allow you to close that artery without causing a degree of narrowing or stenosis. I think if there's a diseased artery there, we would tend to make a longitudinal arteriotomy that we might have to then patch. So once we've got everything controlled, we'd fully anticoagulate the patient, intravenous heparin. Dose is a bit of a... We could use an ACT machine, but we range between 3,000 to 5,000 units intravenously as a one-off dose. We then control the vessels, transverse arteriotomy. We would then... My practice would be to check the inflow first. So you choose an appropriately sized Fogarty embolectomy catheter. You make sure the balloon's not inflated. You insert the catheter always under direct vision into the lumen. It's really easy to actually insert it in the layers of the artery and cause a dissection. So it's got to be truly in the lumen and pass it gently up. And if it is true fresh clot with no underlying atherosclerotic disease, the catheter will generally sail up. And then you pass it up, there's markings on it, 5 centimetre markings, based on the imaging.
On the catheter?
Yeah, on the catheter. So you think, I'm above the clot. I will then gently inflate the balloon whilst retracting the catheter so you can actually feel it engage the artery. I think if you just inflate the balloon when it's static, you have no idea if it's engaging. You don't want the balloon to burst or damage the artery. So gently retract it, inflate the balloon, keep it inflated, and gently retract it down. Hopefully with a good retrieval of clot. And I keep doing that until I have one complete trawl with a catheter.
And the inflow control is with just a sling?
So the sling, so if there's thrombus there, you can sometimes when you open up the artery, you see the thrombus pulsing. Mm-hmm. So with a sling, we would double sling it. The sling would be wrapped around the artery twice. And always, advise your assistant that when they do get clearance, pull up in the sling. A healthy artery should include it.
Otherwise there'll be
there'll be a lot of
hemorrhages.
And then once you got it cleared, we do the same with the runoff vessels, and that's why you make the cut just above any arterial bifurcation, because you can keep one of the bifurcation arteries closed with a sling, so the catheter will selectively go down the other one and vice versa. And it's the same principles. Once done, most of us would tend to instill some heparinized saline down the vessels and then close the arteriotomy.
How would you close it?
Depends who's doing it, depends how big it is and the size of the vessel, really. The common femoral, there's not cutting a corner, but I would tend to use continuous proline, something like a 6-0 proline double-ended. And again, ideally when you're closing an artery or suturing for an artery, you want to go, the needle should always be passed from inside, go through the intima to the outside, so you're not creating a dissection. Because if you pass the needle from the outside of the artery, comes through, you could, by definition or by theory, you could dissect the intima off. But if you're doing it continuous, you don't have that luxury, so you'd always go outside to in on the inflow side, because the direction of blood flow will keep any intimal flap up.
Yep.
And then you'll go inside to out on the runoff side.
Yep. Any
concerns, just do interrupted for all your stitching.
Mm-hmm. Okay. The other question I was going to ask you was about anticoagulation preoperatively. Would you have anticoagulated these patients preoperatively?
Good question. We get asked that a lot. Different units do different things. I think the purpose of anticoagulation preoperatively is to try and stop that embolus propagating. But bearing in mind, if we're going to intervene, we're going to go to theatre as quick as we possibly can. Our thinking in our unit about anticoagulating them preoperatively is the patients are frail. There might not be a really good candidate for general anaesthetic, and they might need more than just an embolectomy. They might need fasciotomies. So regional anaesthesia can have a big bonus here. And if you fully anticoagulated someone, that puts the risks of a hemorrhage into the spinal column can be quite significant. So we would tend not to anticoagulate. We get to theatre as quick as we can, we then get a big bolus of intravenous heparin followed by formal anticoagulation. But other units will use heparin infusions. Our view is it takes quite a bit of time for that heparin infusion to really get therapeutic, and then you need to reverse it to go to theatre.
You mentioned fasciotomies. What is the role of fasciotomy in?
So the role of fasciotomies is when we do, if it is a true acute limb ischemia and we are successful in clearing the clot, you're going to get reperfusion of the muscles. The muscles don't like it. They will swell, they reperfuse. The muscles in the lower limb and the upper limb, they're encased in the thick fibrous compartments. That allows the muscles to work. But of course the muscles swell, the fascia of these fibrous compartments don't allow the muscle to swell, so it just starts to compress the capillaries, the veins, and ultimately the arteries, and you get compartment syndrome. So, as I was saying, if you're going to consider an embolectomy, consider fasciotomy. If you've considered a fasciotomy, just do the fasciotomy. Upper limb, very rarely do you need to do a fasciotomy. Myself, is sort of out with my remit because it's very rare. There's also a lot of compartments in the hand that you need to consider, and our practice is to get a plastic surgical support or a hand
specialist
to come in and do that.
What about post-operative care for a patient who's gone through the procedure? What are the kind of things that you will be monitoring?
So things we monitor are, you've got to think, what's caused the embolus is usually cardiac. Have we got the myocardial infarction adequately treated? Is it AF controlled? Those are the things that kill the patient. So an embolectomy an acute limb ischemia has a mortality of about 30%. And that's not because we're bad surgeons doing a bad operation. We're not even in a cavity. It's a function of a bad heart or bad underlying disease process that caused it. So they're not without problems. So you're looking at the cardiovascular support. You're also looking at limb perfusion. It can reocclude. You may have damaged the artery with an embolectomy. You've also got to be wary of compartment syndrome. If you haven't done a fasciotomy, we'll make sure it's written all over the op note. Please beware and call me.
How would they test for compartments?
Again, the main thing is clinical. It's going to be excruciatingly painful, really, really painful. They won't want to move their leg. It's almost resistant to morphine. You touch one of the compartments. It tends to be the anterior compartment that suffers first. You'll see it be tense. You touch it, patient will scream. There's other methods you can do. If you have like an arterial line set up, you can stick a needle into it and monitor the pressures. Yeah, pretty sore, yes. But it is a recognised method.
And what happens if they reclots? With the re-imaging followed by surgery, or?
Definitely, I would re-image. But it depends what it was. If it was a true embolus, re-image. You just don't know the extent of where the clot is now, and it might mean it's not going to be another embolectomy. You might end up having to plan for a bypass procedure. So you want to know where you're going to get your inflow and where you're going to put the bypass onto.
You can find other episodes of Surgery Talks podcast on iTunes and Spotify. You can also follow us on Twitter. Thank you for listening.